Welcome to today's video. We're covering an important topic, some key investigations used by the rheumatologist. Today's topic is going to be covering some of the first line and most basic tests that a rheumatologist will request, particularly when considering inflammatory arthritis and differentiating this from non-inflammatory arthritis. Okay, so as usual, I'll start with some basics. Itis is normally the term used to describe inflammation. Now, rather unhelpfully in rheumatology, we have osteoarthritis, which is actually more of a degenerative process where there's an improper repair mechanism. But you do get body growth, so it's kind of kept hold of that itis term, even though this isn't really an inflammatory or autoimmune complaint. If you contrast that with rheumatoid arthritis and psoriatic arthritis, these are conditions where your immune system is actively attacking the tissues around your joints, giving rise to red joints, hot joints, swollen joints, and damage from immune attack. And that is really the crux of the matter when it comes to seeing a rheumatologist. We can support for osteoarthritis at the present stage. We don't have the breadth or depth of drugs for interfering in that disease process that we do for inflammatory conditions. And you want to know if you have an inflammatory condition because early treatment results in better outcomes. So these tests are helpful. I'm going to split the tests into two non-specific generalist tests, just looking for evidence of inflammation, and two tests that are a bit more targeted towards inflammatory arthritis. I'll say what these are, why we use them, and what the major pitfalls of these are. Okay, so the first one is the C-reactive protein, often just shortened to CRP. This is a very common test in medicine. We use it because it's a really good indicator of a coordinated, orchestrated chemical pathway known as the acute inflammatory pathway. Essentially, that is triggered by a variety of initial triggering responses coordinated by frontline cells in our immune system, and the release of a chemical messenger, think of it like a battle order, is sent called interleukin 6, and interleukin 6 commences this pathway, this cascade of processes acting on multiple parts of the body, including the liver, which produces, among other things, a protein called C-reactive protein. And we studied people who had inflammation, and we found this protein, and then we studied more about how this protein was made. And we've been able to use this test to provide us a clue. Yes, there is acute inflammation in that person. It does nothing for telling us why. So if you have an infection, you'll have a CRP rise in most situations. And if you have inflammation, you will have a CRP rise in most situations. So it's not that specific as to why it's there, but it's pretty sensitive, and it's usually detected if there's a substantial amount of inflammation. Crucial word there is usually, because like with everything in medicine, nothing is 100% sensitive, nothing is 100% specific. So why might you not have a CRP rise? Well, the immune system is capable of lots of different ways of enacting itself. Just like the military, you may have the ability to send a message via secure satellite communications or over the radio, or maybe by text message or email. If you take out one of those, that doesn't mean you prevented the military from functioning. So if you take out the pathway of interleukin 6 and the acute inflammatory pathway, you are not left with a completely inept and incapable immune system. So if the inflammation in your situation is not part of this acute inflammatory cascade pathway, maybe you won't see a CRP. Sometimes inflammation that is very localized, so we see inflammation in the spine, for example, in conditions like ankylosing spondylitis, doesn't cause a measurable change in the blood of a CRP rise. So commonly, despite there being inflammation in the spine, CRP levels can be frustratingly normal. So psoriatic arthritis and ankylosing spondylitis, it's maybe less useful than, say, rheumatoid arthritis. What else could cause that? Well, it's made by the liver. So if your liver's really badly functioning, it's not going to make as much CRP. And if you block interleukin-6, which rheumatologists sometimes do with drugs like tocilizumab and sarilumab, then you can't make CRP. So that's the other thing that's important. Let's imagine you are being given this drug that puts you slightly increased risk of infection because we're blocking that pathway. Now you pick up an infection, you're really poorly, you're in hospital, the doctor does the CRP and says, you're fine, don't worry about it. Actually, you aren't fine. You're blocking that pathway, and we shouldn't falsely reassure ourselves that the CRP being normal means you don't have an infection. And then finally, there might be some genetic reasons why you don't produce CRP that are very rare. Okay, useful test. What's the next non-specific inflammation marker that we often talk about? It's called the ESR, the erythrocyte sedimentation rate. And this is such a badly understood test, even among doctors. Does it have value? Yes, it does. Are there problems with it? Yes, quite a lot. Literally, what you're measuring is red cells falling out of solution. So you take a purple top tube, so-called EDTA tube. The EDTA binds calcium and stops your blood from clotting. That's not particularly relevant, but this tube has to be filled right to the top because the dilution by the EDTA is really important when it comes to measuring the ESR. That tube is, some of that blood is removed and put in a specific kind of test tube. And over time, gravity means that the red cells, which are normally free flowing throughout blood, they will fall out of solution to the bottom, leaving the plasma at the top and the red cells at the bottom. You can measure how fast those cells fall in millimeters per hour, I think it is. And that gives a clue to inflammation. Now, this is where I often catch medical students out, mainly just to try and highlight to them the complexities rather than being cruel. Because when we conceptualize, well, what would make red cells fall faster or slower, people sometimes think, well, if you've got inflamed blood, then it's going to be stickier blood. And I guess that means the red cells will fall slower, because if I put a rock into a swimming pool, it's going to fall really quickly. But if I put a rock into a swimming pool full of syrup, which is, let's call that the inflamed swimming pool, it's going to fall slower. Except that's the opposite. The ESR goes up with inflammation. So your cells are falling faster. So how can that be? Well, the reason is it's not measuring the thickness of the blood, it's measuring other factors. So your red cells in inflammation may have a tendency to clump together, causing these kind of stacks of red cells called rouleaux. So it's a bit like putting the rocks together and making them into a giant boulder. And the inflammation can produce a lot of proteins, and those proteins have on them charges from the electrons, giving a force, a van der Waals force. Think of it like two magnets of the same polarity. If you put a South Pole magnet against a South Pole magnet, they repel one another. So if you have a lot more of these proteins and these great big clumped up red cells, they're pushing each other apart, causing them to descend at a faster rate. And so really we're not measuring any one thing, because there's so many things going on there that although it is noticed to go high in inflammation, it doesn't nearly as specifically tell us it's inflammation in the way that the CRP does. So extra levels of protein, problems within the blood, but actually there are practical considerations. The ESR can change according to the time of the day you've had it taken, your gender, how long it's left itself on the lab bench, was it taken and the sample filled right to that fill line. So it's a bit of a, in some ways it's a bit of a useless test, but it can still be really helpful. So for example, lupus patients, they get inflammation attacks that aren't via the CRP IL-6 pathway. So they may have a really high ESR and a normal CRP. So it does have value. It's just maybe more limited and needs to be interpreted with more caution. Okay, so those are the non-specific inflammatory tests. What about ones that are a bit more targeted towards rheumatoid arthritis? Well, we've got two antibodies that we use. The first is the rheumatoid factor. So often I get patients coming in and they might say, I've come to see you, doctor, because I've tested positive for rheumatoid. Or sometimes they come in with really bad joint symptoms and they say, but it can't be rheumatoid because I tested negative for that. So just to dispel the myth, there isn't a rheumatoid arthritis test. There isn't one thing that's going to say, yes, you do, no, you don't. It's all about a picture that you paint, pieces of the jigsaw puzzle put together, and then trying to look at the whole picture. So rheumatoid factor is an antibody. You can get multiple different types of rheumatoid factor, different immunoglobulins that will make it. And we test that antibody, and we've found it's more commonly associated with arthritis. So how good is it? Well, if I were to take 100 patients who are under the care of a rheumatologist with a confirmed diagnosis of rheumatoid arthritis, around about 2/3, say 70-odd%, so 70 in that 100, have rheumatoid factor. So it's quite useful. But there are 30 people odd in that room who've definitely got arthritis, but would have tested negative. So testing negative for rheumatoid factor doesn't mean you can't be in the room of people with arthritis. Okay, what about if I take another room and I fill it with 100 average people with a positive rheumatoid factor? So these are people who've gone to see their doctor and they've been told they've tested positive for rheumatoid. Around 2/3, maybe 70 or so out of that 100 will indeed have rheumatoid arthritis, so the test was helpful. But again, there'll be 30 or so people in that room who were told they were testing positive for rheumatoid arthritis when they have no arthritis. They just have a rheumatoid factor. So that is useful, but it's not completely sensitive or specific. How about the anti-CCP antibody? Well, this is quite helpful. We've seen anti-CCP or citrullination happen from certain bacteria in the mouth, so it's given us clues as to, the cause of rheumatoid. I won't go into that in this video. It's similar and slightly different to rheumatoid. It's similar because of how sensitive it is. So remember that room with our rheumatoid arthritis patients. If we took a typical room of 100 rheumatoid arthritis patients, we have a similar number testing positive, 2/3, maybe 70-odd%, 70 of that 100, they have a CCP antibody. But again, 30 don't. However, in the room with the people who've tested positive for CCP and been told they've got rheumatoid arthritis from the blood test, not from the diagnosis by a rheumatologist, we now only have maybe 5 to 10 people who walk out of that room with a CCP antibody which isn't related to arthritis. So it's much less common to have a CCP antibody that isn't of significance, that isn't of potential concern. Obviously, if both antibodies are strongly positive, then that increases your chances. And this is the pieces of the jigsaw that I talk about. So both antibodies are strongly positive, and your CRP is up, and your ESR's up, and you have clinical signs, and you have a family history. The more bits of the jigsaw, the more confident your rheumatologist can be that you have the condition, and also a bit about your prognosis, how likely it is you're going to need specialized therapies, or more, how likely it is you'll have aggressive disease. Things can cause these antibodies to rise without significance. We don't have all the answers, but if you're a smoker and the older you get, you're more likely to have antibodies like rheumatoid factor. But we see rheumatoid factor coming up in other rheumatic diseases beyond rheumatoid arthritis as well, and in some viral infections. So again, it's not completely unique to our specialty. So I hope that video has given you some insights into these blood tests, some of the benefits, some of the downsides. And if you like this video, then give it a like or a share, and a comment below will be helpful. Thank you.